CFS Support Group. I'd like to say welcome. I would also like to thank the staff and the technicians here at the Glazer Auditorium for helping us out today. I would especially like to thank the Continuing Medical Education Department here at Swedish. They made it possible for us to use this space. So before I get started, let me remind you that there will be a question and answer period following the presentation. So if you could please hold your questions until that time, that would be great. Let me tell you a little bit about the man you are about to hear from. So Dr. David S. Bell is a world-renowned authority on ME/CFS, as well as a clinician, researcher, author, and lucky for us, speaker. After obtaining his undergraduate degree from Harvard, he went on to receive his medical degree from Boston University. His postdoctoral training was in pediatrics. He had been in private practice in Lindenville, New York for many years when, in 1985, nearly 220 people in the surrounding area became very ill with a debilitating and mysterious disease. We now know that this disease was myalgic encephalomyelitis, as the World Health Organization calls it, or chronic fatigue syndrome, as we call it here in the United States. This illness cluster in Lindenville started for Dr. Bell a study of the illness which continues to this day. Dr. Bell is the author or the co-author of numerous medical articles on ME/CFS, and in 2003 he was named chairman of the Advisory Committee for Chronic Fatigue Syndrome at the Department of Health and Human Services. He also served on the board of directors for the International Association of Chronic Fatigue Syndrome. His publications include A Disease of 1,000 Names, The Doctor's Guide to Chronic Fatigue Syndrome, and my personal favorite, Cellular Hypoxia and Neuroimmune Fatigue. Yes, I'm very proud of myself for pronouncing that. So until his retirement several years ago, Dr. Bell continued to practice general medicine in Lindenville, New York. Roughly half of the patients seen at that practice suffered from myalgic encephalomyelitis, fibromyalgia, orthostatic intolerance, or other similar diseases. We, as patients, came from all over the world to see him there. And now I am thrilled that he has come to see us here. So without further ado, please welcome Dr. David S. Bell to the stage.
Thank you very much. Can you hear me okay with this?
Yes.
It's a great pleasure for me to be here. It's something that I have really felt is the second half of my career is just starting. And I retired a few years ago and I was bored out of my mind. My wife couldn't wait to get me out of the house. She said, go do something. So, but it's amazing. Without an office staff and things like that, you can't really practice medicine very well. So I have two patients that I still am following and taking care of. But it became clear to me that I really want to try to do something in the field of chronic fatigue syndrome. Every 5 years or so, I get very enthusiastic and I say, you know, this is ridiculous. The fact that doctors still don't even believe it's a real illness, and you know, let's do something. So I've started a new practice, which is part of my retirement. That's why I put my email address down on the board. What I would like to do is to give talks like the one I'm going to give today, try to get people enthusiastic. There are certainly going to be things that I'll say that you may disagree with, and that's fine. I love to discuss these kind of things at scientific conferences and talk for hours on some small details that people will have different thoughts about. But I would really like to do something that would allow the ME/CFS community to get re-energized, to start doing something. When that happens, and it happened in AIDS, when that happens, the money starts pouring in from the government. So everybody knows how well-funded the AIDS organizations are. And now, when you have researchers like Dr. Nancy Klimas, who says half of her patients have AIDS and the other half have ME/CFS, and the ME/CFS patients are bedridden, housebound. The AIDS patients are, they feel great. They're doing wonderful because they have good treatments. And I would like to see something like that happen in the ME/CFS community. So if any of you know of places around the country who would like to have a talk, please don't hesitate to give them my email address. I also am doing some consultations for Social Security and things like that. But the second half of my career is off to a start.
Thank you.
This is an unnecessary slide now for physicians. They have the need for that slide to Now, one of the issues in ME/CFS is that everybody is an expert. You go to your doctor, and your doctor says something totally absurd like this: you're not getting enough calcium, and what can you do? You listen to all these experts, and at a certain point, you just turn it off. You just click, turn it off, and that is a self-protection mechanism, and it's good. On the other hand, sometimes you may hear something that actually will help you, and you need to be able to filter through that to be able to make use of it. The biggest recent thing has been an exhaustive study by the Institute of Medicine. The National Academy of Sciences came out with virtually a book called Beyond Myalgic Encephalomyelitis Chronic Fatigue Syndrome, Redefining an Illness. I was not on that panel, and so I can say whatever I feel about it. I can say good things or bad things, but there is the option here with their suggestion that the illness be redefined or renamed Systemic Exertion Intolerance Disease. My first response to that is, oh no.
Yeah.
However, there's something to it. First of all, it's the Institute of Medicine. You don't get higher than that. This is the best of the best. It's not some, crackpot pediatrician in Lindenville. It's not some, anyway, the Institute of Medicine did this exhaustive study, and we'll come back to it a little bit, but it really presents us with an opportunity to talk to doctors and say, hey, look, read the Institute of Medicine's publication on it. I gave a talk very recently to a group of physicians in Ithaca, New York, and after the talk, they, I think, have a different view of ME/CFS because of the prestige of the Institute of Medicine. That this is not just some little fantasy that people are dreaming up. This is a very specific and real disease. And they call it a disease. They don't call it a syndrome. They don't call it an illness. This is a disease. And they say it should be called S.E.I.D, and we'll come back to that at some point. Diagnostic criteria, let's not go into that. I mean, people have been talking about diagnostic criteria for ages. The basic issue here is that with exertion, people don't do well. Now, what is that exertion? It could be intellectual exertion, it could be physical exertion, it could be emotional exertion. Anything that requires an increase of oxygen uptake and usage will cause a decreased ability to function. Now, this is the primary symptom of whatever this disease is, ME/CFS. And most people don't realize that they have it. So here is an experiment that you can do to see whether or not you have S.E.I.D. And my hunch is that everybody in this room does have it, even though you may not be aware that you have it. What you do to experiment is you get up on a Thanksgiving day, you go out and go shopping, buy a nice big turkey, and then cook the turkey and all the fixings and the gravy, and then invite your family and your children and your grandchildren and your great-great-grandchildren, and they all come over. You have the TV on loud, the kids are running around, everybody's having a great time, and see how you function the next day. That's exertion intolerance. Now, everybody would say, what's the big deal about exertion? All you did was cook a Thanksgiving dinner. I mean, that's no big deal. It is a big deal because it's exertion. And it's that exertion intolerance which really defines this illness. Put aside all those other symptoms, the light sensitivity, noise sensitivity, odor sensitivity. There are a million symptoms. But it's the exertion intolerance which is at the bottom of this whole thing. And you can test this for yourself. The greater the exertion intolerance, the greater the severity of the illness. So if you go out and jog around the block for an hour, which your doctor tells you to do, then watch and see how much that exertion causes you to collapse, to get sick. That will tell you the severity of your illness. Nothing else will be as accurate as that. No blood test can tell you, no questionnaires, but if you go out and do some exertion, you will know whether or not you have exertion intolerance. If you do, then this is your illness. What Jamie had mentioned about Lyndonville, there's something really important about Lyndonville that I need to express. The Center for Disease Control has said that there are no epidemics of ME/CFS. They're out of their mind. I love them dearly, but they're completely crazy on that. Lyndonville outbreak was defined by my wife and myself as a geometric area of 25 miles surrounding the town of Lyndonville, absolutely rural. I mean, no small cities nearby. And 202 people got sick over a 2-year period. Now, when this happened, I was the only doctor in the area, so I had kind of a lock on the patient population, which may or may not be a good thing. But what was interesting is that there were several things that jumped right out. First of all, genetics were very important. There were several families where 4 children in the family all got sick at the same time. Now, one of the children, if you took all 202 people who got sick and you lined them up in front of a bunch of experts, half of them would be diagnosed as having fibromyalgia, and the other half would be called orthostatic intolerance or postural orthostatic tachycardia syndrome or whatever. And this is the reason that I wrote that first book, Disease of 1,000 Names. because whatever happened in Lindenville was one thing. There was not 10 different illnesses that came in as a coincidence all at the same time. It was one thing. And because I was able to follow this group of people for a long period of time, I was able to see that their diagnosis could shift. So some people who were prominently chronic fatigue at the beginning, severe sore throats and lymph nodes, after 10 years, they had fibromyalgia, muscle pain, joint pain, headaches. Now, did they get a new disease? No. This is the evolution of whatever it is they had. So my personal belief, and this is where we could get into fistfights if you wanted, and I've seen that at a medical conference. It's wonderful, actually. My personal feeling is that all of these different names, chronic Lyme, chronic mono, POTS, all of these are referring to the same basic underlying disease, and it's one disease. I don't feel that these are a whole bunch of different illnesses that are sort of merging into one another. It's, from my opinion, one disease. And, you know, it doesn't matter whether or not we agree or disagree on that, but until somebody can explain to me why of 4 kids in a family, 2 have fibromyalgia and 2 have chronic fatigue syndrome, and then I won't change that view. If you find a single one of these diseases that is cured by something, then holy smokes, we're in good shape, because then it will affect the other things. Okay, there are lots of different aspects to ME/CFS. There are probably 5 different aspects, one of which is infection, and that's what we're going to talk about now. But the reason this is important is that everybody gets confused by these different aspects. With the issue of infection, there have probably been 200 studies looking at this or this or this, and I've contributed to that confusion. We did the retroviral studies, and we did this, and we're always been looking for new infectious agents which will explain the disease as it explained AIDS, because AIDS suddenly just vanished as a diagnostic enigma when they found the HIV virus. Infection probably initiates 75% of people with ME/CFS. Not all of them, but about 75%. And certainly in Lindenville, there was an infection that was going around. I saw many people who were brothers, sisters of my patients who had whatever the infection was and got better in 3 weeks or a month. My own children, actually, one of them was sick for about 6 weeks. And I said, oh no. And then that child got better and has never had any problems since. So that an infectious agent of some kind usually initiates ME/CFS. And there are many infectious agents that can do it. Perhaps the greatest study that has been done to date is called the DUBO Infection Outcome Study. And here's where the CDC has really done a good job. This was a wonderful study. And it's just a shame that it hasn't been better understood or used. Okay, what they did is in one county called Dubbo County in Australia, they prospectively went to all the physicians in that county and said, anybody who comes down with mononucleosis, Epstein-Barr virus, or Ross River virus, or Q fever, we're going to study them like crazy. These are 3 different infections that we know can set off ME/CFS. Now, it was a prospective study, meaning they got them at day one, the day they walked into their doctor's office and said, I don't feel good. 101 patients with Epstein-Barr virus mononucleosis. This is a DNA virus. 88 patients with Ross River virus. This is an RNA virus, totally different type of virus. And 65 patients with Q fever, which is a rickettsial infection and not viral at all. Totally different types of infections. Then they were followed very carefully. Blood draws, questionnaires. They were followed every 2 weeks for a year. At 1 year, 6% of the subjects met criteria for chronic fatigue syndrome. And what is extraordinary is that 6% of patients with EBV, 6% of patients with Ross River, and 6% of patients with Q fever all got chronic fatigue syndrome. I mean, that's extraordinary. It's not like Epstein-Barr virus causes chronic fatigue syndrome. These 3 different agents, along with many others that we can talk about, causes 6% of the population to get chronic fatigue, or ME/CFS. What that tells me is that 6% of the population has an underlying condition that makes them susceptible with coming down with this horrible illness. 6%. It was probably around 6% of people in Lindenville that got sick during the time of our outbreak. So they studied, because they had all this information and this data. They said, well, what is it that predisposes them to getting sick? Maybe it was their psychological status. Had nothing to do with that. So they were able to say that emotions were not a predictive factor, nor was premorbid psychiatric status. You can be crazy as a loon, and that does not increase your risk of getting ME/CFS. Now, if you're crazy as a loon, it makes it much harder to cope with the illness. But it doesn't make it more likely that you will get the illness. Most important predictive factor was the severity of the ongoing infection. And that's something that as a clinician I was able to see all the time. If I saw somebody who at 6 weeks was bedridden, oh, they're in trouble. You know, they're in trouble. Whereas somebody else at 6 weeks was still going to school or still going to work every day but didn't feel well, yeah, they usually did much, much better. So that DUBO infection outcome study, very important. And what it means is that something occurred in Lindenville that affected 6% of the population. I'm pretty sure it was a bacterium, which was, it doesn't matter what it was. We weren't able to prove it, and it's not something that is particularly common, but it just went through the community. Now, these are things that we really know can set it off. Important here is Q fever. The Inuit-Melnick virus, I think, is very important, but there are lots of them. And I've seen patients who had ME/CFS following psittacosis. Their parrot gave them psittacosis and they never recovered. One of the patients I'm following now got sick with a fungal infection, which is very rare, and recovered from it completely but didn't get better. Okay. There was a very interesting study done a while ago where somebody was studying the effect of interferon treatment on hepatitis C. Interferon has been a standard treatment for hepatitis C. Prior to treatment, 22% of them had chronic fatigue, but not meeting CDC criteria. After the interferon treatment, 70% had chronic fatigue and 30% had CDC criteria. Those with chronic fatigue were less likely to clear the virus. What this means is that the treatment for hepatitis C actually could turn regular run-of-the-mill fatigue into chronic fatigue syndrome. And that's kind of interesting. Parvovirus, interesting studies. Jonathan Kerr did a bunch of studies on this. Now, this is important. If you take one of the cytokines called interleukin-2 and you inject it into a healthy volunteer, these are the symptoms you get. Now, interleukin-2 is an important cytokine. It's used in the treatment of cancer, and it's been studied extensively. If you had a healthy person and you give them a shot of IL-2, they would have severe fatigue and muscle and malaise and fever, chills, nausea, diarrhea, the whole thing. And this really looks like ME/CFS. If you take influenza as a model, what happens is that initially you get a viral infection. Let's say Saturday you're at the grocery store and the person next to you in the checkout counter has flu. They turn and they cough right on you and you breathe it in, and at that moment you have the influenza virus growing in your system. But you feel fine. And you continue to feel fine Friday, Saturday, Sunday. But Sunday afternoon at 2 o'clock, you start to get the flu. And you just start feeling exhausted and sick and weak. And you start feeling, I think I got a fever. It all starts. And it's very, very specific when it starts. What happens at that moment is that the body starts secreting these cytokines. And the cytokines are what make you feel sick. After a bit, the cytokines do their work inside the body, and your body eradicates itself for the immune infection, or from the infection, and then the whole system shuts down. Cytokines go away, you get better, and after a week of not feeling up to par, you're back to your normal self. In ME/CFS, the same thing happens, but it doesn't shut down. So that the cytokine response continues and continues to make you feel sick, and it just goes on indefinitely. It doesn't stay at the same severity. Now, interestingly, there's some recent work about the possibility of autoimmune disease. And many patients, when I ask them, and I usually on the first visit take about 2.5 hours and really ask them details about that initiating infection. And many people will say, you know, I got sick and so did 3 other people in my family, and on the 4th or 5th day I was starting to get better. I was going to go back to work and I was starting to get better, and then bang, it got much worse. Well, that is a typical type of history for an autoimmune disease. And that's what happens in rheumatic fever and a number of things like that. As you're improving, the body's immune system makes an autoantibody, which then causes you to get sick again. So the work by Flug and Mella, which they're presenting this week over at the Invest in ME conference in London, their work is really important because I think that they may be onto something with the autoimmunity. Mady Hornig recently published this paper with 650 patients. I mean, that's a huge study. And they found what they're calling an immune signature, a very specific set of cytokines which are present either in increased or decreased amounts. And it may be that we'll find that if you get sick with Epstein-Barr virus, your immune signature will be different from if you get sick with Lyme disease, but that hasn't been looked at yet. We've been able to, notice how I take credit for this by saying we've, by looking at the cytokines in spinal fluid, and there appears to be an immune signature in spinal fluid as well. This is work done in Washington by Baruniak and others. But it may be that in the future you can take a blood test and look at this immune signature and say, oh, you're in for a long course. Okay, so that's what I'd like to talk about as far as infection is concerned. It's one specific area. It's an area that causes enormous confusion because people will say, oh, I don't have chronic fatigue syndrome. I've got chronic borreliosis, or I've got chronic whatever. And it becomes very divisive, and it becomes, but from a practical point of view, it also does something else. It also tells the physicians that they don't know what the hell they're talking about, and we're not gonna pay any attention. And that really sets back the whole field. And I don't think that it's justified. Until somebody can show that there is a real difference between someone with ME/CFS, which is started with Epstein-Barr virus, and ME/CFS that is started with histoplasmosis. I won't be convinced that they are separate illnesses. Okay, the second thing that I want to talk about is the issue of fatigue. Fatigue is something that does not occur in chronic fatigue syndrome. How do you like that? Fatigue is a recovery state. If you are a physiologist, if you take a frog and you stimulate the muscle of the leg with an electrode, as many sadistic physiologists are likely to do, the fatigue is present, but that fatigue is recovery. And recovery is exactly what does not occur in ME/CFS. People will say they have fatigue because they have no other word to define it. The Inuit Eskimos, I was lucky and was able to practice in the Arctic Circle for a while during my training. And the Inuit would have about 50 different words for snow. There's the granular snow, there's the powdery snow, all of these different types of snow. If we had that kind of ability to differentiate types of fatigue, we'd be in much better shape. But as it is, people assume that you're tired, you're fatigued after being up all night working, or after doing some exertion, after running a marathon, or whatever. That's not what happens in ME/CFS. I was lucky to have in my practice about 30 professional athletes, and a couple of them were marathon runners, and they knew fatigue. And they were able to articulate very clearly, this is nothing like the fatigue I get after a marathon. You know, that fatigue was a good fatigue. Now, maybe that was mixed in with some endorphins or whatever, but it was just different. It didn't feel the same as the kind of fatigue that they had now. The fatigue they have now, they describe it as an exhaustion or a weakness. Both of those terms are technically inaccurate because, like fatigue, it doesn't occur. But it limits the activity of that particular person. In addition, there's orthostatic intolerance. Orthostatic intolerance is a very simple concept which occurs in everyone with this illness. It means that people are intolerant of being in the upright position. Orthostatic intolerance historically has always been thought to occur because of decreased blood flow to the brain. When that happens, you have a near fainting spell. It's called presyncope. And many people will feel that presyncope, and particularly if you've had a tilt table test, you might actually actually have a full-fledged syncope, but you will feel as if you're about to pass out. When you're in the grocery store and there's a long line at the checkout counter, you're standing there and suddenly you just say, I'm going to sit down. And that is orthostatic intolerance. I like to ask, as part of my seeing somebody, how long can you stand without moving? How long can you do it? And they would say, gee, I don't know, never did that. Because they have to keep moving. If you're walking in the aisles of the grocery store, leaning on the cart, yeah, you can do that. But standing still at the checkout counter, no, you can't do that. It's not simple tiredness, it's not anhedonia. Anhedonia is the lack of motivation which occurs in depression, and it's not sleepiness. Post-syncopal fatigue is related to a decreased blood flow in the brain. And we're going to talk about that in a little bit of detail coming up. Orthostatic intolerance is divided into 5 simple types. And we used to test people for these 5 types with a simple test that was devised by David Streeton, who was at Syracuse and who was a master of this area before he passed. One type is postural orthostatic tachycardia syndrome, POTS. Another is orthostatic hypotension. Third is orthostatic narrowing of the blood pressure. The fourth is diastolic hypertension, and fifth is delayed orthostatic hypotension. You can test for all 5 of these things with a simple test. And that is, you have your patient lie down on a table for 10, 20 minutes, and you take their blood pressure and pulse every 3 to 5 minutes. And you'll get normal readings. Then you have them stand up next to the bed, just like that, but not leaning on anything, not moving, not doing this, but just standing there. And you take their pulse and blood pressure every 3 to 5 minutes. I don't think that I've seen a single patient who has been normal on this test over the years. I don't remember if we did that at the time I first saw Jamie. Did we do that?
Yes, I remember doing that.
Uh-oh. Did you pass out?
I did not pass out, but I was not comfortable.
Okay, this is a normal set of readings. This is the blood pressure up here. A little dip initially, but then it goes on and it's perfectly fine. This goes to 15 minutes, but actually Streeton did it on his normal population of, I think, 75 nurses at Syracuse Hospital for 90 minutes. And after 90 minutes, their legs ached, but they had no change in pulse or blood pressure. Here's the pulse. Initially, you get a little bit of a rise, but not over 100. And then it stays the same. In ME/CFS, there are different patterns. And these patterns will change so that over a period of time, a person with POTS, the next time you do it, they may not have POTS. They may have narrowing of the blood pressure. Now, here is the resting phase. The yellow is the blood pressure, and here is the 130/82. As you stand up, the blood pressure starts to narrow, and at a certain point, the pulse pressure, which is the difference between the diastolic and the systolic, in this person went down to 10 millimeters of mercury. It's interesting that you cannot circulate blood without a pulse pressure greater than, I think, 20. So that a pulse pressure of 10 means that you have a continuous pressure from the heartbeat, but not enough to circulate blood. You need that pulse pressure, the strong systolic, the relaxing diastolic. And this person also had a pulse down here On standing, that pulse went up to 144. You cannot circulate blood into your brain with a pulse of 144. You can stay alive, but you can't circulate blood. So what happens at this point is the person collapses. Our nurse Paula was extremely good at preventing people from dying from this test. She could predict. There's a look in the eye that occurs just when people are about to go down. And she terminated the test at the right, but she didn't terminate it because of the numbers. She terminated because of the how the patient was doing. Same thing happens on the tilt table test, but I think that this test is more accurate than the tilt table. This is a orthostatic narrowing of the pulse pressure primarily. Starts out normal here in rest, and then it just goes down to a tiny little pulse pressure of 4. But this patient did not have postural tachycardia. This patient had orthostatic hypotension. He or she, and I don't remember, got up and the blood pressure went right down to 0 and continued like this. What's really interesting is that this patient had her blood pressure go down to 0 and she was able to stay standing. That's extraordinary. People say that patients with chronic fatigue syndrome are wimps. They're not. They are so used to this happening. They say, okay, I'm going to get up and, yeah, okay, well, I'm well unsteady, it'll pass. And they just get on with whatever they were doing. So they are so used to it that they don't respond to it the way a normally healthy person would. If you give a healthy person isoproterenol or something else on a tilt table test, and this happens, you're looking at a lawsuit. It's not good. Now over here we've got the blood volume things, and what I tried to do for many years was to correlate the blood volume with what type of orthostatic intolerance, and I couldn't do it. Now, a normal red blood cell mass is 18 to 24 milliliters per kilogram, and this person was 14.8. So this person had a blood volume which was 56% of a normal blood volume. We'll come back to that in a second, but that is a very important part of this puzzle. This is a 14-year-old girl who had a SPECT scan. There have been many SPECT scan studies, and every SPECT scan study is abnormal, but it's different. In this particular young lady, this is starting at the back of the head and keeps on going like this, and then it runs up here. If you look at this part right here, it starts, and you can see a little bit there. You can see that the blood flow in the temporal lobes here is clearly reduced comparing this side to that side. Down here it looks even more dramatic, but this patient had a very abnormal SPECT scan. Now the SPECT scan, basically it was used looking for brain tumors and things like that, and it will show decreased perfusion because of a brain tumor, but it's not all that helpful in ME/CFS, except the studies have clearly shown that there is abnormal blood flow in the brain. Now, one of the important things to remember about the SPECT scan is that it normalizes blood flow between the vertebral arteries and the brain. So if you have decreased blood flow in the vertebral arteries, that decreased blood flow will not show up on a SPECT scan. And essentially, everybody with ME/CFS has some abnormalities in blood flow in the brain. The Japanese have done some very elegant work using a machine to measure intracranial middle cerebral artery Dopplers, and that hasn't become widespread, but I'm hoping that that will become more used, because it's a very, very nice set of studies. Yeah, here we go. I used to get really angry when patients would come in and they'd say that their doctor said that they were nuts and they needed to see a psychiatrist, and I'd say, well, okay, no. But the psychiatrist wasn't much help. Psychiatrist, I gave this slide in a talk I gave at the University of Rochester School of Psychiatric. There were 50 people in the audience. They were all interns, residents, psychiatrists. And University of Rochester is a very Freudian school. They do a lot of psychoanalysis and stuff. This was not easy. No, not too many smiles. It was clunk. Okay, the fourth area that I'd like to discuss is called the vasculopathy. Something is wrong with the blood vessels, and this has been proven in many, many, many studies. However, it's complicated. Vance Spence did some elegant studies. He was from England. He hasn't done any in quite a while. But it showed there are four basic areas of this abnormal vasculature. Reduced circulating blood volume, we'll talk about that in a little bit. Reduced venous return to the heart. If you measure the return of the blood to the heart in the standing position, it's abnormal. The reduced cardiac output in the standing position, not in the lying down position. If you go to a cardiologist and have your heart tested, they will lie you on a table and do an ejection fraction, and that's always normal in ME/CFS. But if you have the kind of test that looks at the cardiac output while you're standing, it's always reduced. And then there's increased peripheral resistance. David Streeton did some elegant studies on this, looking at the receptors in the legs. What that means is that in a normal person who is standing, the leg blood vessels get the blood back up to the heart. And in ME/CFS, that doesn't happen. So let's look at just the first of these, reduced blood cell mass. Now, if you take a person with ME/CFS and you do a blood volume test, what that test is you take out a sample of blood, you label the red cells with chromium-51, and then you inject that blood back into the patient. So it's the patient's own blood. You're not injecting somebody else's blood. And then you wait until it circulates around, take a blood sample, measure the chromium-51. You can calculate extremely accurately the total blood volume in the person, which means that if you were to take a person, remove his or her head, tip them upside down, you would be able to measure very accurately the total amount of blood in the body. If you do that to somebody with ME/CFS, 80% of them will have less than 80% of normal blood volume, which means that a normal person has 5 quarts of blood. 80% of the people in this room would probably have 4 quarts of blood, down a quart. This is very important. If you don't have full blood volume, you don't get blood to your brain very well. Now, let's say you're in a car accident and you lose a quart of blood. You get by because the body adapts to this very quickly, and it makes up that quart very quickly. But in ME/CFS, there is no recovery from this. It doesn't get made up. And we looked for literally 3 years at the different mechanisms for why the blood volume was down. And I was at a conference just very much like this. And I said, for 3 years we've been working on this, and I have no idea why the blood volume is down. The ADH is normal, it responds, it's low, but it responds normally. This enzyme is normal, this hormone is normal, there's no sense to it. And somebody from the audience spoke up and said, well, it's because you have small blood vessels. Holy smokes. So I said, are you a physician? He said, no, I'm a plumber. So what happens is that if you have a house and the pipes in the house are all 1 inch, and you take all of the heating fluid from that house and you measure it, you get it at a certain volume. Then you change all the pipes to 3/4 of an inch and you measure all the volume, it'll be down, it'll be low. And that's exactly what happens in ME/CFS. For some reason, there is a vasculopathy where the blood vessels are hyperreactive and they will become narrower in certain places, particularly the brain. Other places are in the gut, and that would be something we know happens in irritable bowel and a few things. People with, there's a gynecologic condition where the blood vessels in the uterus are narrowed and you get a lot of uterine pain.
Endometriosis?
No, not endometriosis. I don't know, the name skips me now. But the volume in the blood is reduced, and the body thinks that it's just fine. There are 3 organs that are given priority for blood flow. If you're in a car accident and you have loss of a quart of blood, 3 organs are high priority to keep the perfusion going: heart, lungs, and kidneys. The brain doesn't count. The brain really just, it wasn't very important part of the evolutionary scale. And so what happens in ME/CFS is that somehow the brain gets less blood flow and the body thinks that that's just fine. There's no need to get upset about it, no need to make more antidiuretic hormone or more blood. We did a lot of studies with erythropoietin to try to stimulate blood flow, and just, the body says, hey, what are you giving me this stuff for? Because I don't need it. I'm fine at 80% or 60%, as that one patient was in. Septic shock is a very interesting thing. It's an acute infection causes cytokines released, many other cytokines aside from tumor necrosis factor alpha. And after a while, it affects the blood vessel reactivity, and at a certain point, the changes become irreversible. And I think that there's something about that in ME/CFS. Now, it's not fatal as septic shock is, but at a certain point, the changes in the blood flow to the brain are irreversible. And that's when a person goes on for the next 20 to 30 years with basically the same overall level of function. However, I think that that point is at around 6 weeks where it can be changed. As I was mentioning a little bit before the lecture, we did a lot of work giving people intravenous saline in order to flush their brain out, get their blood volume high, even though that would cause them to be anemic. They got their blood volume high and they felt wonderful with the saline. There were 3 young people who were in the process of coming down with ME/CFS. And if you ask any clinician who has seen a lot of patients with this, you can tell. I mean, it's not a fatigue like regular fatigue. These are maybe young people who were good athletes or whatever, and now they just can't get out of bed, they can't go to school or whatever. For these 3 young people, I gave them daily intravenous saline, and it stopped that process. And all 3 of them got better and never got sick again. And that's why I think that this is such an important thing to come to understand. I think that at 6 weeks, you can reverse the process. But after 6 months, it may be irreversible. Bad news for the people in this room. I think they're all past the 6-month part. Now, with blood volume expansion, you can temporarily make the symptoms go away. Mass trouser experiment. This was really interesting, and this is something that we published. I published with David Streeton. What he would do is he would have a person. First of all, anybody know what mass trousers are? Mass trousers are carried in every ambulance, so that if you have a fractured hip, you're put in these mass trousers, which are zipped up from the feet right up to the neck, and then with a pump, you pump up the pressure so that it's like a blood pressure cuff, but it presses against the whole body. So let's say you're in a car accident, you have a fractured hip, you get pumped up in the mass trousers, you can't move. You're absolutely immobilized. It's like a cast, and it's very good for ambulances and things like that. So anyway, we had a pair of these, and we put them on people, but not pumped up. The first time I met David Streeton, I brought a patient with me, and I wanted to see what he did. And so he had the trousers on, and the patient had a very reproducible type of orthostatic intolerance. She was a PhD, but she would start slurring her speech at about 5 minutes. And at that point, I knew you could swear at her and she wouldn't remember it when she got back. It was wonderful. Except that she was a nice person and I didn't really feel motivated. She started to say, oh, the pain is terrible. And she really looked kind of drunk. So then he pumped, and also her blood pressure and pulse were doing funny things. Then he pumped up the mass trousers, and 7 seconds later, and I was watching this and I was stunned. She goes, "What happened? I feel wonderful. What's?" And it was so dramatic. And the only thing the mass trousers did was to push the blood up into her brain. That's the only thing that it did. And she felt just wonderful. And so we did this on a lot of people. And in fact, that is what led to David Streeton's study of the decreased innervation of the lower extremities. And this is a physical result of decreased blood flow through the brain. Cardiac output and end arterial pressure, let's forget those, although they are important. One of the things that happens in ME/CFS is that what we're talking about is 4 or 5 different areas. Each area has 4 or 5 different areas, and each of these areas, and we're talking 20 to 30 different areas, have been studied. So, for example, the natural killer cells. There are 100 studies on natural killer cells, and most of them have been abnormal, but the scientists can't agree. And what they're looking for is the natural killer cells to be the same in everyone. And that would mean that the natural killer cells are causing the illness. But that's not true. Whatever causes the illness does cause the natural killer cells to be off in 60% of people. Same thing with all of the other studies. And as a result of that, everybody's been confused. Well, what's causing the illness? What's causing the illness is behind all of the things that we're talking about. It causes decreased blood flow through the brain. It causes something to change after an infection. But it's that unknown thing behind there that's the important thing, and that has not been found. Although you will know what it is at the end of this lecture. I hope you're excited about that. Decreased venous return. Okay, treatment. I'm not sure what these are, but take them for a couple of weeks and let me know how you feel. I hate to say this, but that's what I did. For example, there was a paper that came out and said calcium channel blocker made somebody get all better. So I did a study on calcium channel blockers, and it just had very hit and miss type of response. So then the lady says, I feel a lot better since I ran out of those pills you gave me. In terms of treatment, there are some principles. First of all, comprehensive medical care. When I saw patients, I wanted to make sure that they had their routine medical tests done. You can still get bowel cancer, you can still get breast cancer. You need to have your routine medical care done on clockwork. And it doesn't matter whether or not your doctor understands ME/CFS. Coping and pacing. This is the responsibility of the patient. There is no way that an expert can tell how much activity you can do. So if I look at somebody in the audience here and I say, you need to be out and doing 10 hours of activity a day, or you need to be bedridden. No way, you just can't do that. But every person knows what their level of activity is, and they know what is the payback if they should go beyond that level of activity. And nobody can tell you that. No expert can give you any hints there. You have to decide what to do, and you decide how to use that activity. One of my heroes is Laura Hillenbrand, and she's not my patient, so I can talk about her because everything I know about her I read in the different stories. She would use her activity very wisely. So I would guess that she has 2 to 3 hours of activity a day if you add it all together. A lot of the day is spent in preparation for her good time. And then at her good time, which is between 1 and 3 in the afternoon, she'd take half a cup of coffee. I'm guessing, this I don't know. She would do this and she would do this, maybe take a little coffee, maybe do a little bit of this. And then she'd be in good shape for about 2 to 3 hours, and she'd write like mad. And she was very talented, and she wrote unbelievable books. I don't know how many people have read the books she's written, but Seabiscuit is about this used up old horse that never couldn't make the grade, an owner that was used up and thrown out, and a jockey who was over the hill, and somehow they managed to put it together and win races. And her current book about not broken, people with this illness get broken so easily. And she figured out how to not get broken. And she found somebody who was probably a true hero and wasn't broken, but not because of this illness. But this is something that I used to tell every one of my patients. Find what it is that you want to do in life and figure out how to do it. If you put everything together, you could probably get a couple of hours of activity and do whatever you need to do to get those 2 hours of activity and use them properly. Use them for what your dreams are made out of. Symptoms, what to treat and what not to treat. From my perspective, it didn't matter at all. From the patient's perspective, it does matter. The thing that matters is how much activity you have in a 24-hour day. But none of the treatments, with the exception of blood transfusion and saline infusion, would change that at all. So I could make somebody's headaches go away, or I could make somebody's sleep get much better. There are a lot of symptoms you can treat, but that doesn't change the overall amount of activity. So you have to decide what your symptoms are that you want to treat. You've got 3 to 5 minutes in your doctor's office to get this across. And if you go beyond that, you're lost. I mean, it's hopeless. Visit's over, you might as well go home. So you go in there and say, okay, my biggest problem is sleep. Oh, okay, sleep. Okay. And then there are some things that can be done about that. There are lots of treatments for sleep. Some of them will work, some of them won't. Whatever you try gently at first and watch your reaction to it. If, for example, you know of a medicine that will just knock you for a loop, how many people here have had that experience? Lots. Okay, that's a good medicine. You know why? Because if you take it at really small doses, it'll help you get a good sleep. The tricyclic antidepressants happen to be the most common in that class, and the normal antidepressant dose for Elavil, for example, is 150 milligrams 3 times a day. If you gave somebody 50 milligrams, they would come back and say, "You tried to kill me. I couldn't get up for 3 days. You know, it just knocked me for a loop." But 10 milligrams would have them sleep all night. Now, maybe it's 12 milligrams, maybe it's 8. Here's where you have to find the dose that works. And you can do it. You take a pill cutter and you cut the smallest pill, and you can experiment, and you can find the dose that works to improve your sleep. Learn the tricks. There are many different tricks, and I would learn this from my patients. One of the tricks is people would wake up at 2 o'clock in the morning and they would be wide awake. Sleep cycles are completely screwed up in this illness. And so what do you do at 2 o'clock in the morning? Television, no, forget it. There's not much on television. Some vampire movie or something. Well, what do you want to do with your life? Well, I want to pray. The best thing to do at 2 o'clock in the morning is pray, or read poetry, or whatever. Here's where nobody's going to bother you. You've got about an hour and a half of awake time, which you might as well do it some way, and you figure out what it is that you need to do to pain in the necks out here, doctor. Yeah, this is not good, but this is life. One of the reasons I put this slide up is that people have been so disrespected with this illness. And what I like to tell them is, okay, you've been disrespected. Get over it. Let it go. Put it behind you. You're not going to change anything. People want to go in and slap their doctor. Now, even if you did that, they call security and that's it, and you never get to see that doctor again, which might be a good thing. But, it's not going to do you any good. Feeling sorry for yourself is one of the worst things that can happen to a person with ME/CFS. Don't feel sorry for yourself. One of the things that I evaluate in the first visit is how much people feel sorry for themselves. Oh, poor me, I can't do this. I used to be an athlete and now I can't do this. We have a big sign in the front of the office that says, whining is permitted for 10 minutes only. And it's an important thing. Look, hey, your life is different. How long have you been sick? 3 years. You're going to be sick for at least another 3 years. Figure out what you want to do and do it even though you're sick. But it's very hard. I don't mean to imply that we should be heartless, but at the same time, you have to say, come on, get over it. Do something. Look at Laura Hillenbrand. She's sicker than you are. Look at what she's done. She doesn't need Social Security. She's a millionaire. Okay, these are the recommendations from the Institute of Medicine. I don't want to go through the first three. The committee recommends that this disorder be renamed Systemic Exertion Intolerance Disease, S.E.I.D, and for people who meet the criteria. In my experience, just about everybody who has ME or CFS would meet the criteria of exertion intolerance. Exertion intolerance is actually not a bad name, although I had a hard time with it initially. I'm beginning to say, it's really highlighting the most important aspect of the whole disease. And it may be the thing that causes a paradigm shift in the medical profession. So I'm telling groups of physicians, and I like to talk to groups of physicians, that you need to call it S.E.I.D. and forget this chronic fatigue stuff. You know, everybody's tired. Physicians are tired. Primary message is that ME/CFS is serious, chronic, complex, multi-system disease that frequently and dramatically limits the activity of affected patients. What people don't ever get across to their physician is how limited they are. They show up in the doctor's office, they look pretty good. They showered and, you know, this is their day. Tomorrow they're going to be a wreck. They won't get out of bed. But today they look pretty good. And the doctor doesn't ever ask the only question that's really important. How many hours in a day can you function in the house? You know, cooking dinner, tending to the kids, talking to neighbors, whatever. Healthy people, all healthy adults, have at least 12 hours of upright activity where they function. Patients with ME/CFS, if it's mild, they have from 8 to 10 hours of activity, and that's pretty good. They can do a lot with 8 to 10, and even work, although they have to make some modifications. Moderate disease, 4 to 8. Severe disease, less than 4. People who are diagnosed usually have much more severe disease than the mild cases. There were lots of mild cases I saw in Lindenville. I didn't even diagnose them. The reason I didn't diagnose them is that they wouldn't be able to handle it. You know, they were coping quite well with their life as it was, and they wouldn't be able to handle some unknown disease. And so therefore I'd say, well, you know, you're doing pretty good. Didn't need to be slapped. Okay, these are more quotes from the Institute of Medicine. Seeking and receiving a diagnosis can be a frustrating process. This is not something any of you need to know about. I mean, you all know this very well. Estimated at 17 to 24 billion annually. That is a low number compared to what it really is. It's extraordinary how expensive this disease is. Most patients, how many patients here have had extensive cardiac tests? A few. 95% of those cardiac tests are totally unnecessary. If you happen to be 60 years old and you get chest pain, which occurs quite often in ME/CFS, you get an angiogram. Unnecessary. But the doctor doesn't want to get sued, so you get the angiogram. Okay, let's talk about this last segment, which is the mitochondrial energy production. There is no question about the fact that the mitochondria don't work properly. Mitochondria are the little energy-making packets that are in each cell. A normal muscle cell has 300 to 500 mitochondria, and it produces ATP from oxygen. Okay, what happens with oxygen is that it gets into the cell and it goes over to the mitochondria, and then in a complex series of reactions, the oxygen is turned into reactive oxygen species, ROS, which are very destructive and dangerous to the cell. But in the process of getting turned into that, it creates lots of ATP. Prior to aerobic metabolism, oxygen-based metabolism, we had anaerobic metabolism. That was when we were single-celled organisms and like little slugs. Anaerobic metabolism is real, but it produces for 1 ATP in aerobic oxygen metabolism. you get 23 times as much ATP. So aerobic metabolism is what makes us run, makes us go. If you're running a 100-yard dash, you run like crazy for the first 90 yards, and then your aerobic metabolism runs out, and you switch to anaerobic metabolism, the same kind that slugs use. And you struggle across the finish line, you hurt, you're exhausted, you're this, but that's what happens when you're in anaerobic metabolism. In patients who have normal metabolism, oxygen-based metabolism, if you do an exercise test, and this is done in most professional athletes, along here is the amount of exercise, and along here is the time. There are two different things that are measured. You're breathing in a tube, and one thing that's measured is carbon dioxide. So as you're doing your exercise, you start not breathing out very much carbon dioxide, and then up here you're breathing out much more carbon dioxide. At the beginning, you're breathing out in and out oxygen, and then up here is the oxygen max. At a certain point, these two things cross. That happens in everybody. If you're an elite trained athlete, it may be up here that it crosses, where you evolve from aerobic metabolism into anaerobic metabolism. So there are a few ways you can, jumpstart this, like with steroids and stuff like that, and that's why people use these different things. But basically, you function well on aerobic metabolism, and you don't function well on anaerobic metabolism. Okay, so Stacy Stevens did this experiment. She was at the University of the Pacific. Many of you may have seen her or not. She did this experiment, and she did the standard exercise test on people with ME/CFS. And it was a little bit low. Let's say it was right here, whereas normal is up here. And people would say, well, that's just because they're not exercising. I mean, this is what you would expect for not exercising. And she didn't buy that. She said that, no, that doesn't feel right, because she saw a lot of athletes who had ME/CFS. So what she did is she did exactly the same test the next day. And what happened the next day is the anaerobic threshold dropped from up here to down here, 40% drop. This is virtually impossible to occur. It cannot occur with a psychiatric disease. Let's say that you are loonier than a fruitcake. Every day your anaerobic threshold would be the same. It'd be crazy, but your anaerobic threshold would not change. If you had somebody who was here and they started to exercise, they would go up to, here, maybe a little more. Or if you had somebody that was exercising and was here and they stopped exercising after a year, they'd go down maybe to here. But something like this, unheard of, just impossible. What does this mean? What it means is that in a normal person with ME/CFS, they are functioning at their maximum right here, because that's their anaerobic threshold. You ask them to go to the supermarket with you, and they say, no, I just can't do it. And the reason they can't do it is they are maxed out at their anaerobic threshold. It's not like they've been running a race. It's just that they just can't do it. They're maxed out. Whereas if they do force themselves to go to a shopping, their anaerobic threshold will drop dramatically. And when this happens, you feel really sick. Everybody who has ME/CFS knows what this feels like. They did that Thanksgiving dinner, they had all the grandchildren and the neighbor's grandchildren and the neighbor's grandchildren's friends, and They were just completely maxed out and felt very sick. That is when you have used up your ability to function on oxygen metabolism and you have switched over to anaerobic metabolism. And this can be measured accurately with this test. It's a 2-day exercise test. It's not easy, and some people have very bad recovery from it. I mean, this is not something you want to take lightly. If you need Social Security disability because you can't function, this is a way of proving that you can't function. You take something like this, and that's about, for a heart attack patient, it's last days, But a person with ME/CFS, they rest for a week and they get back to here. And so something is happening set off by this first day of exercise, which causes the body to drop its anaerobic threshold. And this is just extraordinary. The only explanation for this is that there's something happening in the mitochondria that is abnormal. And it's a reversible mitochondrial deficit. So here to here, and then after a week of rest, you're back up here. Here, you're functioning at your maximum, doing just, let's say, 3 to 4 hours a day, which is perhaps your level of functioning. But your mitochondria get injured when you exceed that anaerobic threshold. And that's called post-exertional malaise. It's the exertion intolerance part of S.E.I.D. It's one of the reasons why S.E.I.D, I think, is actually an important development for us at this point. Maybe it'll get this across. Stacy Stevens has done, 5 years worth of these tests. Nobody takes it seriously. They're being done at Ithaca. We have a NIH grant that's been submitted. Probably won't get funded because who cares? But this is important. This is really important stuff. They want a physiologic answer for this illness, and here it is. You talk to any exercise physiologist, and they'd say, well, first of all, this can't be correct. That's day 1, that's day 2. There was a mistake someplace. They wouldn't accept it as being correct or real. So the 2-day exercise test, I think, has a lot going for it to give this illness legitimacy and to make it something very real as a mitochondrial disorder. But it's different from the other mitochondrial disorders. The known mitochondrial disorders are abnormalities in the mitochondrial genetics, but there the mitochondria are messed up, and they're always the same. They're messed up, but they're the same messed up every day. So let's say you have a mitochondrial disease called MELAS. It doesn't change. I mean, it gets slowly worse, and it's usually fatal. But that's due to mitochondrial abnormality in the mitochondrial genome. This is not. This is something that's related to function of the mitochondria, which can repair itself over time. Okay, this is a complicated slide, but here is the grand overall scheme. I've always envied the physicists who are looking for the answer to everything in the universe. What is it? The grand overall design. Well, anyway, here it is. Anything that causes increased oxygen uptake will go and cause excess free radicals. And that's true of running, emotions, studying, whatever. These free radicals are taken care of in the body by a set of enzymes: superoxide dismutase, catalase, and glutathione. Those 3 enzymes take care of your free radicals so that you're not injured by them. If you don't have those enzymes, the mitochondrial membranes get disrupted. There are enormous changes that happen. Oxygen is an extremely toxic substance, and anybody that's interested in this area, there's a book by Nick Lane, L-A-N-E. He's a physiologist, and he's written a lot about how the evolution of oxygen has occurred. Used to be 1% of the atmosphere, now it's, 17% or something. But he's a wonderful author, and anybody who's interested in it can read his books. They're very reader-friendly. At any rate, if you have S.E.I.D, you do something which causes increased oxygen uptake, and you can't handle it because something is missing, I think, in those 3 enzymes. Now, all 3 of these enzymes can be measured, and some people have measured some of them and found abnormalities, but nobody's taken it seriously. I think that if there was a good big NIH study which looked at these 3 enzymes, compared them to healthy controls, you'd find the answer right there. So the excess free radicals will cause 3 different things. 1, impaired mitochondrial function, because it disrupts the mitochondrial membranes. And because the mitochondria is not working well, it doesn't produce ATP properly, it makes your anaerobic threshold fall, and you'll experience fatigue. Actual fatigue, the kind of fatigue that's real. Secondly, excess free radicals are known to cause a vasculopathy. They will cause vasoconstriction. There are all sorts of things that go on when you have free radical poisoning, and it affects the vascular tree. And I think that the vasculopathy actually causes the majority of the symptoms. It causes that pre-syncopal thing. Because you can reverse all of the symptoms of this illness, even for 1 day with a blood transfusion, means to me that all of those symptoms have to be related to blood flow in the brain. Now, there are problems with this, and I like to argue with my friends about it because this is a really intriguing area. But I think the vasculopathy causes a lot of the main symptoms. And then the third thing is impaired immune response. If you have free radicals and reactive oxygen species, it'll impair natural killer cell production. It'll put out all sorts of immune things which are very complicated, and I don't begin to understand them. When it's that complicated, I say, I'm going to leave that to Nancy Klimas. She's got that covered. And but we do know that the free radicals will affect immune function. So I think that this is really the main thing that's at work in this illness. And that's it. So I'm going to quit at that point, and we can either take a break or we can do questions.
Have they found any correlation between ADHD and the symptoms?
No. Now, is there a correlation? Absolutely. There's no question about it. Because the cognitive problems of ME/CFS are significant. But it just hasn't been studied. You know what? I'll repeat the question so that. But nobody is, even straightforward things are complicated in this illness, and that is a complex problem. Because if you have a kid with ADHD, you're not a kid, but
I'm the one. I was diagnosed at 40.
At age 40? Yeah, I would imagine it's probably, if you have ME/CFS, it would be related to that. But if you have an 8-year-old with ADHD and then they get ME/CFS at age 10 or 13, impossible to separate that or to drive it apart.
Who's going to turn this, Dr. Mouse?
Is that better?
Oh, yeah.
For the recording.
Oh, yeah.
Yep, good.
I've heard it called acquired ADD. in CFS?
Yeah, acquired ADHD, yeah. No, not hyperactivity.
ADD.
Yeah, ADD.
No,
But, not the hyperactivity part.
I wonder if you could go back to the slide about the exercise, the VO2 max, there. Would this be, because this is what happens to me. This is the most important slide that I saw the whole stack. Because this is a crash that I feel a lot of us go through that drives us and our family and our employers and friends batshit crazy. Because
Yeah.
we can't get our arms around that.
Right.
And to me, this is like, Joe Sixpack over here. I don't know nothing about nothing, but that's like a biomarker. If we
Oh.
prove that. Can this be used as a litmus test?
I think so, yes. Now, this I think is so important because it has just been unheard of. The reason nobody ever thought of doing this test because you don't ever change your anaerobic threshold, but it does change in this illness, and now there are several studies that are really showing it. The study that we've submitted for an R01 grant has got lots and lots of patients, and we're hoping that that's going to help. But I do have one or two patients who have had the 2-day exercise test, and they regretted it afterwards because while this happened, they got sicker because of it. And again, use your own experience. If you go out and run around the block, 5 or 6 times, and I'm sorry?
Where would you get that test done?
Yeah.
Who does it?
Okay, here, Stacy Stevens is the only one I know that's doing it out here. She was at the University of the Pacific. She's not at this point. Dan Peterson is doing it in his office, and I think Stacy's doing it in his office for him.
She
And
also
then
has a company called Workwell. It's in
that
the
was
Bay
what
Area.
Stacy Stevens.
Yeah, Stacy Stevens.
Yeah, on the East
I
Coast.
gave her information. I got it. I give it to you.
Okay.
On the East Coast, the only ones that I know who's doing it is at Ithaca.
And that's Betsy Keller.
That's right.
Maybe you could just email all that.
You talked a lot about the fact that blood flow is abnormal. One of the things my doctors have said is basically, there's no change of color in my legs, there's most of the time, no edema. There's not the usual signs that you see of somebody that has that kind of blood pressure issue. How would you answer a doctor that says, well, your legs look fine?
Right.
I mean, he believed me, but,
You can't do it by, just observing the legs. Now, Julian Stewart likes to talk about the purple people eaters, where the kids have purple legs.
Yeah.
And yes, that does happen. I've seen it quite often. But most of the time, you don't see much.
exactly.
The problem is the important issue is the blood flow through the brain. And that you can't tell. There's no test that we have commonly available to us that will really give us a measurement of what is your blood flow through the brain.
But the answer, when I talked about the orthostatic, that your blood basically went to your feet, the answer was no, because your legs aren't purple and they aren't swollen.
Well, in order for them to be purple and swollen, you need 2 extra quarts in your legs rather than the 1.
Okay, so there's a missing cord that is the reason you don't see it.
I think that's true. That in a normal person, when you stand up, I'm not implying I'm normal, but you have 1 quart of extra blood going from your system into your legs. Now that's normal, and you compensate for it just fine. No change in blood pressure or pulse. But if you start a quart down, that 1 quart goes down there. You won't see it with the purple, but it's going to be less in your brain. There's a couple of places where the blood is stored for emergency use. One is in the mesentery, and that's perhaps the most important storage area. But the brain is disrespected when it comes to blood distribution.
Going specifically to sleep, I thought I heard that you mentioned something called L-Bill. It's my husband who's got this. And holy crap, he's now Ambien 6 years, 2.5. Then I think he takes a couple other things in addition to the Ambien. So I'm like, is this L-Bill perhaps an option? And did I catch phonetically what it is called?
I'm sorry, is this for you or for your husband?
This is for my husband.
Okay.
Yeah. So he's the one
And
that-
he has a problem with initiating sleep?
He has a problem with initiating sleep, and then he wakes up at like 1 to 2, and he takes a half Ambien then, and then he's been playing with Sonata as well. So it like frightens me what his.
First of all, don't be frightened of that. This is a standard thing in moderate to severe CFS. My personal approach to this is you find the medicines that work and use them. Now, that's been my approach since 1985, and so far I've had no reason to not use that approach. Many people will say, oh, you can't use these drugs because they're all toxic and they're bad. And okay, I mean, that's a philosophical point we could debate, but they will do things that can be quite helpful. When people, how many hours of activity does he have? 4. Okay, if a person with 4 hours of activity and lousy sleep gets good sleep, they'll go up to 5 hours of activity. Doesn't cure anything, but they will feel a little bit better and they can get a little bit more done. There are many agents that can be used, and they can be used together. And this is just what I've done over the years. The number one agent that I like is Elavil at extremely low doses. So it comes in 10 milligrams, and again, 150 milligrams is a standard antidepressant dose. But the 10 milligrams, you can experiment with that with 10 milligrams or 20 or 30 or 50. And then you find the dose that works for you. But that by itself will sustain sleep through the night. It won't initiate sleep very well. So to initiate sleep, I like melatonin at a dose of about 20 milligrams, about an hour before bedtime. Now, that's a big dose, but melatonin is essentially a benign drug. No one's ever, it's been around for many years. They use 3 milligrams here, maybe 5, but I think 20 milligrams an hour before you want to go to bed. That can be added to Ambien or Sonata, again, an hour before bedtime. Or it can be used with any benzodiazepine. And I think that benzodiazepines like Xanax or clonazepam or Valium, I think they're very, very useful. Doctors will say, I'm not going to give you that Xanax because it's addictive. It's not addictive for anybody with ME/CFS. You know why? If you take an increased dose, you get tired. So I've never seen anybody get addicted to a benzodiazepine who had ME/CFS. Now, you use the dose that works. And a fourth thing is Benadryl, 50 milligrams Benadryl over the counter. If that's used every night, it loses its effectiveness. But if it's used occasionally, it can be used. The other trick to sleep is sleep hygiene techniques, and they're very important actually. And to, I forgot what I was going to say. So.
iPads, iPhones, computer.
Oh yeah, that's all part of the sleep hygiene. If you are watching the Terminator movie, and what that is, it visually goes right in through your optic nerve, right into your brain, and that's not a good idea if you have a sleep disorder with some primary insomnia and stuff like that. So.
Okay, thank you.
Shortly after I was diagnosed with ADHD, then I also went to see about getting, help with pain, and my doctor just kept saying, oh, you're going through withdrawal, because I was recovering alcoholic. And I said, well, then why is all this happening? Or I said, I need to see somebody because this is not okay. For this to continue. Like, it took me 3 days to recover for working 2 days, and I waited tables. So, this is, by day 2 of working, I was struggling. So, they had me on all these different kind of drugs, and I opted out on that. And my question, I guess, is, what are your feelings about medical marijuana? Have you done any studies with medical marijuana on this particular kind of illness?
No, I'd be in jail if I did that in New York State. But many of my patients would smoke pot. Whether or not that was because it really helped them, helped their sleep, I have no idea. I never did a study on that, and I don't know if that was something that is true or not. It's not something that was talked about and nobody has really studied that yet.
I hope they do.
If there is lower blood flow through your brain, does that mean that the cognitive impairment is going to stay regardless? I mean, are we losing brain cells?
No, very important question. There's cognitive problems with this illness, and there have been probably $15-20 million worth of cognitive studies done, but nobody has ever looked at orthostatic intolerance. So, and that's changing now. If you did a cognitive study on somebody after having them stand up and be working around this, it's not going to be very good because you'll be having more problems. If, on the other hand, you were lying down and resting for 2 days before the cognitive test, I bet it would be much better. My personal feeling is, and this is an important issue and one which many people would disagree with, my personal feeling is that the cognitive changes are due to orthostatic intolerance and not due to loss of brain cells. The reason I think that is because of what people have told me when I put them on the saline infusions and what that one patient has said after the blood transfusion. She said, holy smokes, I can think just like when I was 15 years old. And that would imply to me that this is not a dementia in that sense. Can people have combined dementia and ME/CFS? Yes, I've seen people who have had that. Yes?
How does this correlate with the spots? Like I have like millions of spots on my MRI, the little high intensity.
Yeah. Okay, how does it correlate with the spots on the MRI? That's a question that nobody can answer. People interested in the illness have kind of given up on the MRI and looking for the high intensity lesions because nobody takes them seriously. The other day, I work at night in an MRI place. And the other day I was talking with a MRI radiologist about the spots. I said, well, you must see these spots in people with chronic fatigue. He said, oh, no, that's just old age. And he doesn't take them seriously at all. The original studies, I think, were very impressive, that they are a real finding. And I think that there's something to those spots, but I have no idea how to answer that question. What would be interesting is to see if the spots were not there after a week in bed. Yes?
How does the impaired mitochondrial function tie in with this, or does it?
Tie in with this? Oh, anaerobic means no mitochondrial oxygen to ATP. Aerobic means oxygen goes through the mitochondria and makes ATP. So this has to be related to mitochondrial function.
Okay. So do you ever prescribe any sort of like antioxidants to try and get the mitochondria to work better?
Oh yeah.
Okay.
Oh yeah. In my practice, I have tried experiments on everything imaginable that I think is safe. Patients like that, by the way. I give them all the information. I said, look, in advance, if I kill you, I'm really sorry. But I'll say, I've heard somebody's using glutathione and this. I've never used it IV. The problem with the antioxidants, and this is true with all of them, is that, first of all, if you swallow glutathione, it'll be broken down in your stomach by the enzymes. You don't get it to the mitochondrial membranes where it's needed. Secondly, there are two forms of glutathione. There's the oxidized and the reduced. And if you don't get that balance right, you theoretically would make things worse. So what I do is I listen to people who have taken glutathione, and I listen carefully. Now, some people are very good at reporting changes and other people aren't, but that's the way I get my information. I have never found anybody who is taking glutathione supplements or antioxidant supplements to have that much of a change. Yes?
So you talk about too much oxygen, the free radicals and everything. Like my son, who's 7, actually we got him a microscope for his birthday because he was into science. And my husband and I both pricked our fingers because he was very curious to see what like a drop of blood looked like. And my husband's stayed red and normal looking for a long time, and mine almost instantly was like blue-gray. And then at the doctor's office, when they check my oxygen on the finger, it's always 100%. Does any of that correlate at all?
Oh, yes. Oh, yes. This happens to be a subject that Paul Cheney is very eloquent on, and he's right.
Dr. Bill, can you repeat what she said?
Oh, yeah. The question is that when you look at oxygen under a microscope or look at blood cells under a microscope, the oxygen is attached to the red blood cells in different degrees for people with this illness. And that's actually correct. She noticed that with her son at the physician's office. But if you look at different things, for example, the pH of the blood and some other parameters, you will see what's called an oxygen dissociation curve. At what point does the oxygen actually come off the blood? And that is different in patients with ME/CFS than in healthy people, according to Paul Cheney. And I think he's correct, but nobody's ever taken that seriously. Very few people actually understand what he's talking about most of the time. Very bright guy, but he doesn't seem to be able to communicate to the general world of physicians. That's another one of these interesting tests that's easy to do. Look at the oxygen dissociation curve, and it's abnormal. People say there's no test for ME/CFS. I can name you 25 of them right now. One of them is the oxygen dissociation curve. Why is it abnormal? Well, I could go into that, but it's complex physiology, and I'm not sure I understand it myself. So, but it is different, I'm sure.
I have 2 questions. So one is, I had a long-term, like 5 months of perimenopausal bleeding, and I was in the hospital, kept going to the emergency room. And what they did was they would infuse me with saline. And what I realized at the time was, oh my God, I feel so much better.
Yeah.
It was like I was a new human being. And is there any way to get like saline infusions on a regular basis? Because I just think it would help me so much. And then
the simple answer to that is no. Yes, it would help you. Can you get it? No.
Okay.
Now, this is a subject that I've spent a long time thinking about. I had 24 patients where I gave them a liter of saline every day for years and years and years. We were talking about it a little bit just before the lecture. And the majority of patients, vast majority, would feel good. And this is what happens when people, they have a syncopal episode in the grocery store. They call the ambulance, bless you, take you to the emergency room. The ER doc knows that you're a fruitcake, just when you come through the door, say, oh, no, and plugs you into saline and puts you in the corner. And that's just a way to get you out of the way. However, and they forget about you, but after 8 hours, you sit up and you say, hey, I feel pretty good. I want to go home now. Well, you have to sign out against medical. Sure. But yeah, and this was actually one of the things that led me to this form of treatment. Is there anybody who will do it? No. You cannot prove that saline improves anything. Now, Stacy Stevens actually showed that giving normal saline will reduce the amount of anaerobic threshold change. But nobody will ever look at that paper. I mean, that's just one of those things that... And of the patients that I treated every day with saline when I retired, they couldn't get anybody to do it, so they went right back to where they were, which is a shame.
Can't you just continue to hydrate?
Oral hydration doesn't work. Now, you can increase circulating blood volume in other ways. And I remember when in 1994, Peter Rowe came out with the paper on fludrocortisone, and that helped a lot of people. But it didn't help them all that much, and it helped mostly teenagers and not so much adults. But that expanded blood volume. Eating lots of salt, somebody told me that they felt much better the day after they had sushi. One of my patients, who was a little strange, he felt much better after eating a huge amount of oysters. And he wanted me to write him a prescription to have oysters shipped up from New York City. I said,
He needs to move to Seattle.
Yeah, that's the point. By the way, Seattle is a beautiful city. This is the first time I've been here, and it is just lovely.
Come in November.
Yeah, what was your second question?
My second question is, a friend of mine who's a therapist is starting to do neurofeedback, a specific neurofeedback, and they actually have a protocol in this neurofeedback for CFS. I don't know what the efficacy is, or if there have been studies about it, but they also have, like I'm looking at their website, fibromyalgia, depression, chronic pain, all these things that we have. And so anyway, so she wants to try it on me.
Sure.
And I just wonder if there have been any studies that you know.
Yeah. I did a study on adolescents with a hypnotherapist who did biofeedback through hypnosis. And you can modify all the symptoms of the illness except for the exertion intolerance. That's in teenagers. She never published that study, but it was done well. So therapists, I never think that it's a problem to try something like that. Use common sense. If it's working, great. If it's not working, let it go.
It's supposed to improve sleep as well. So.
Yeah. So you don't know until you try it. Because what we're measuring are end symptoms far away from the initiating cause of what I think is the reactive oxygen species, then everybody's going to have a different pattern of symptoms based upon, how they're built. And they may respond better or worse to certain types of therapies.
I don't want to
detract too much from the conversation, but the chronic pain aspect of it, because I have a lot of trouble getting like diagnosis. Like, is there like a sort of a basket that you could put that in? Like, do people have leg pain mostly, or I seem to have like a lot of weird injuries or leg pain that can't really be. There's no cause other than maybe this.
Right.
So I don't know. I don't know what my question is really. Is there, is there something? Is there a common? Is there common stuff that happens?
Yes. Everybody will have chronic pain in a different way. So no, really, this is some people have killer headaches, and the other pain is trivial in comparison. And other people will have the irritable bowel or whatever. In general, what I think is the best thing to do is to find out what it is that makes your chronic pain better. Have you ever been on narcotics?
Yeah, that's not really an option for me, narcotics.
Okay, but if you have found something that is worthwhile, that actually works, then you figure out a way to get them. And the easiest way to do that is lying to your doctor.
I think you're right. I mean, I see your point.
There are a lot of patients of mine who now I run into them in town from time to time, and they say, Vicodin actually does help them. They take one a day, but it really gives them energy, and they like it. And one Vicodin a day I don't consider a bad or tricky narcotic. On the other hand, how do you get one Vicodin a day from your doctor? Well, you go in and you complain about back pain. And do they have back pain? No, but the doctor says, oh, okay, here's whatever. But you have to have a good relationship with your physician. Your physician has to trust you, even though you're lying to him. And you have to be very careful never to abuse it. If you abuse that trust, you're out of luck and nothing's going to help.
Thank you.
I wonder if you have an opinion or observation about a couple of experimental treatments that have been noted lately, rituximab and fecal transplantation.
Yeah. Fecal transplantation as a treatment, I don't know anything about, but that's going to be done in Ithaca. It's interesting. There's a world expert there at Cornell who's involved in the microbiome project, and she's going to be doing that on ME/CFS patients. Rituximab, if I were still in practice, I would be using rituximab, even though it's not been, accepted. This week, I had been kind of hoping to go to the Invest in ME conference, but you talked me out of it. But the first time I went to the Invest in ME conference, the two doctors, Flug and Mella, were there, and they presented their initial study on rituximab, and I was blown away. So I had one goal for the rest of the week, and that was to corner these two guys in a room without anybody else around and really get the details, because it's the details that'll tell you stuff. I've heard for years people say, "Oh, I got all better on echinacea, and I got just it doesn't hold up." And you can always tell because you ask the right questions. So what I asked these two doctors, first of all, because they were cancer specialists and they found this by accident, that's the way real things happen. They weren't just trying to increase their chronic fatigue patient load. They found this by accident. Secondly, they were good scientists, or are good scientists, and so that really counts. The third thing, which is very important, is the severity of the patients at the time they were given the rituximab and how long they'd been sick. If you had a patient who had 3 hours a day ME/CFS, and they've been sick for 10 years. Nothing you give them is going to make a difference except perhaps some blood volume expander. And that will only make a difference for a short period of time. What they found was that these patients who were very sick had a dramatic response, the ones that did respond. Now, this was an initial study. It needs a lot of work, and it's going to be another 40 or 50 years before we find out. So don't get your hopes up too high. That really infuriates me, because there's never been a study like this that has shown this kind of a response in very sick people who have been sick for a long time.
But in Europe, I think there are studies going on now.
Yes.
I think in Scandinavia, but
Yeah.
not here in North America.
Yes, there's a guy out in, not out in Los Angeles, down in Los Angeles, part of the Stanford group that is using it, but it's not in a formal study. And I think that's inexcusable. You know, with this kind of response, there should be studies going all over the place. And, you know, this is an approved drug. It's not a mystery drug. Is it harmless? No, it's got some, you know, real effects. If it works, then this, to me, proves that there's an autoimmune component in here that is being altered by the change in the B-cell population. But I think that the rituximab is the most exciting thing that's happened in a long time.
Is that in a subset of patients, or?
I don't know. You know, what he did initially, for anybody who doesn't know the story, these are two cancer specialists. A patient came in with a B-cell lymphoma, got treated with standard rituximab. That's a normal treatment for a B-cell lymphoma. And she came back in follow-up and she said, my lymphoma's gone away, which is nice. And by the way, my chronic fatigue syndrome, which I've had for 20 years, also vanished. And they sort of, whoa. And so they were astute enough to actually do a study on this. They got 20 people with chronic fatigue syndrome and treated them, and half of them had a really good response. There are lots of little details that need to be filled out here, but and I don't know the latest on that. Yeah.
A while back, there was a guy named Gupta who came up with something called the amygdala retraining program, and every now and then on the web in various places you see variations on this theme. Are you familiar with that?
Yes.
And do you have an opinion on it?
I've never used it to the degree where I could form an opinion. My hunch is that I don't think that it works very well.
Could you repeat the name of what you're
the issue was Dr. Gupta's amygdala retraining program. You know, my gut response is that it's like biofeedback. You know, you can get a lot of interesting changes, but I don't see it as being likely to be the answer for this. Time would tell.
Do you have any thoughts on low-dose naltrexone?
Yes, low-dose naltrexone was first discovered by Susan Levine, and it is the same as low-dose narcotics, like a single Vicodin. And Vicodin is a narcotic agonist, and naltrexone is a narcotic antagonist. But both fill the narcotic receptor. And some people get some response to it. It's worthwhile. Worthwhile as a try. If for no other reason, to get your physician involved. And that can help. Yeah, who haven't I?
It's my sister-in-law who's more scientifically minded than me, but she had questions that I have on my own. She wanted to know why the blood transfusion works, but it works only temporarily. Why is that?
A blood transfusion works because it expands the blood volume, basically taking it back to normal. But the blood cells break down over 6 weeks. So just the normal breakdown of the blood cells, and the body does not feel obligated to replace those.
Okay, and then my question was, in the other slide that you had, where you had the chart, you said that, oh, okay, here. With the vasoconstriction, I have very small veins. I always have a hard time finding, yeah, they have to use the baby butterfly needle when vascular.
Do you have ME/CFS?
I was just given a likely diagnosis about 6 months ago, but I've been sick for a long time.
My nurse, Paula Corser, who was my nurse for 35, close to 40 years, she had tremendous observations about that. She says, first of all, you never should draw blood from somebody unless they're lying down, because they'll pass out. Secondly, their blood vessels are tiny, and I'm sure that's all tied into the blood volume thing. But I didn't understand your question.
Oh yeah, no, I just thought that was interesting too when you were talking about the plumber. I was like, oh, that's why my veins are so small.
Right.
They always have a hard time finding my veins. Okay. So you said that causes reduced blood volume (OI), which I also have pain. Why does it cause pain?
I don't know, but pain, I think, is related to blood flow. The latest in fibromyalgia research is that there's something about reduced blood flow through the muscles which is stimulating the pain. But more than that, I don't know. What I do know is that people who are on the normal saline daily, their pain would be much better. And that one patient who had the blood transfusion, her pain vanished, just completely vanished.
I have a microphone, so I'll use it. So there has been a lot of discussion amongst our support group, especially on the online portion of it, about ME/CFS being possibly reclassified as a somatic disorder. And there are some people who are extremely angry about this. I looked up the definition of somatic, and the literal definition reassured me and made me feel very good. But then someone explained to me that when you put the word disorder after the word somatic, it changes it so that it means it's just another synonym for psychosomatic.
Yes.
And so everyone is very upset about this. And so can you tell me, what is a somatic disorder? Give some examples of somatic disorders. And is it good or bad for us as a community to have our disease reclassified as such?
Well, somatic means body. So a somatic disorder means a disorder that affects the body. And name me one illness that isn't a somatic disorder. MS is a somatic disorder. AIDS is a somatic disorder. Now, the real trick here is the psychosomatic disorder.
Yes.
Now, psychosomatic means that the soma, the bodily part, is really a reflection of the brain's imagining. And the Institute of Medicine report, I think, was very clear. They said, there's no way this is related to emotions. 17% of the American population are fruitcakes. That's scientifically known. 17% of people with ME/CFS are going to be fruitcakes in addition to having ME/CFS. So that are there people who are a little strange with it? Yes, of course. But this illness has nothing to do with emotions, and that's been proven. The Dubos study was the best proof of that, but it closed the door. And the I.O.M. repeated that in its report many times. This is not a psychiatric illness. So psychosomatic, it's not. But is it an illness related to the body? Yes, it is.
So having it called a somatic disorder is not a bad thing. It's not a synonym for psychosomatic.
I think that there would be better ways to spend your energy in calling it, S.E.I.D, for example. Do you call lung cancer a somatic disorder? No, I mean, that's kind of foolish. They call it lung cancer.
I think she's actually talking about a somatoform.
Now that's something different. Somatoform means that it looks like it's in the body. So, that means that it's psychiatric. But no one has ever proven or shown that it's a somatoform disorder. And it works all the time, is you keep it really simple. If you bring in 50 different tests, each one, well, my natural killer cells are not up to snuff, and they don't pay any attention, they'll just throw it out. If you say, I have S.E.I.D, I meet the criterion set in the thing, I can function on a daily basis for about 4 or 5 hours, 2 hours, 3 hours, but if you can say this, and then just leave it at that, because then they have to prove that you're actually out playing basketball. I actually did this with a patient who was a metal worker, and after he got sick, he'd play basketball in the backyard. He'd take the ball, throw it through the hoop, and he had somebody build him a ramp so the ball would come right back to him. And as he began to improve, he would be able to do this for 25 minutes, 27 minutes, 30 minutes. So one day this guy comes into my office, and he was the private detective from the metalworker thing. He said, I have here a tape I took from the bushes of your patient throwing a basketball. I said, oh, am I on that tape? He said, what do you mean, are you on? I said, I used to do it with him. I'd come stop in on my way home from work, and, we'd, throw the basketball. And I said, this is my treatment for him. I want him to throw the basketball. When you get a tape of him doing that for 8 straight hours, then, hey, I'm with you. But right now, he's at, I think, 42 minutes. That's his whole activity in the day. 42 minutes standing up. And can he load metal and carry it up these stairs? So what you have to do is keep it really simple. Can you do 8 hours a day of activity, even a sedentary job, and stick with that? And always just go back to the CDC and the I.O.M, because they won't disagree with the CDC and the I.O.M. Where people get in trouble is that gets lost, and they're talking about natural killer cells and this cytokine and this cytokine, and the judge just throws that out. And, oh, I don't want to deal with that. So you just, I'm sorry?
We haven't gotten to a judge yet. The initial determination was that because he has the job training, he should be able to meet the qualifications of his old job. And yet, there's no way he can work 3 hours a day, let alone 12 hours a day.
So, and you also need to have one piece of physical evidence that shows that. And there are many things you can choose from, including this.
Yeah.
Which is me 5 years.
Oh, you improve brain fog if you look at it.
How do you improve brain fog?
Because during the mental exam, they ask you to remember 8 words, and if you can't remember them a couple minutes later, then, that's what happened with me. I got it on the first try.
Well, how did you pass that?
I did. Use it.
Oh.
Yeah, most people don't actually aren't put through that exam.
I was.
He was. He said they
I was,
didn't
but they
use it.
didn't use it because they denied it before the report was ever submitted back to them. Mine means a minor issue.
Okay, let's see, it's 4:20, so we've been at this for a while. Let's take a couple more questions and then quit.
I got a question. There's some local doctors here, I'm thinking 2 of them, and one has like some label. He came to the CFS group like maybe a decade ago. Busher has some like label where he puts people on some, it's mainly for heart patients. It's exactly what you said about those trousers, except it's supposed to be on the whole body, and it like circulates.
Yep.
PECP,
What is it?
external enhanced counter pulsation.
Have you heard or
Not about that specifically, but my patients got very creative after the mass trousers experiments. Some of them actually bought a set of mass trousers. And when you're in the mass trousers, you can't you know, so there's this one family, you know, the wife would get in the mass trousers, whoops, the wife would get in the mass trousers, and then her husband would prop her up against the sink, and she could do the dishes. And she felt pretty good about it. Another patient got a fighter pilot G-suit, and that actually tries to prevent a fighter pilot from passing out, especially when they go straight up. She said that helped her a lot, but I didn't hear too much more about it from that.
It's like, I know people on the CFS and I.O.M side of things where they've used like that table. The other thing is laying on a mat, which Lisa's EMF stuff. It's local doctor, Lyme doc uses it to stimulate microcirculation. So it's like, I don't hear it being curative, but I hear it like, it's like CFS. If you get a couple percentage points, you know, that's a game changer.
Right, right.
You know, and that's, I got two other ones. I'm just gonna say it. It's like the MTHFR genetic stuff, and then like the Richie Shoemaker mold stuff. You know, which are both genetic stuff. Okay. Do you work with that, or?
Yeah, I don't actually do any active work with that, but it's an enormously complex area, and one of my most severe patients was found to have a nuclear mitochondrial enzyme deficiency in addition. And so I think that's one of the reasons why he's so severe. So I'm sure that there are going to be all sorts of things that come out of that in the future. But I don't know.
You know what? It's like you have enclaves of people doing treatments and protocols. So yeah, you get, you know, like the retraining folks, you know, but there seems to be a certain segment of people who know this methylation, you know, THFR stuff. I actually talked to a CFS patient for sure. So she basically said she did the stuff with Rich Van Conjure, the guy
Right.
doing that stuff, who ended up passing away. And she said that gave her 50% recovery. And then she addressed the infectious stuff. You know, she did like cemented matter with the local doc here. It was sort of like for her recovery was, you know, 50% of the genetics and 50% of kind of dealing with the infectious thing.
Right. Yeah, this is part of why this is so incredibly confusing. Are you improving things because you are improving the end symptom far away from whatever's causing it? You know, like my patient who liked the oysters. You know, the oysters have a lot of salt. The salt increases blood volume, and you know, he was functioning a little bit better. Is it a treatment that is going to work on everybody? No.
But what's your opinion on the mold? People who feel that mold is the main cause. You know, they leave their moldy house and they can walk again.
Yeah, there's no question that, you know, what does mold do? You're allergic to mold, and when you're allergic to mold, you are going to release cytokines which increase the size of the blood vessels, and therefore you're going to have worsening orthostatic intolerance, not just mold, but any kind of allergies. When you get out of that environment, you may actually be better. So no question that some people are very mold sensitive. Some people are sensitive to dirty electricity. This is such a confusing area, but I had a patient who was a school teacher, and he loved to teach, and he could do it, but not in one classroom. And he actually got the school to rip out the wall in that classroom, and it was filled with these dirty wires, dirty electricity that was replaced. He could teach in that classroom. So he taught me a lot. One of the things that he taught me was when you approach your employer, don't be obnoxious. You know, if you think that there's something that's going to make you stay and work, try to make it actually work without being too pushy, because most of the time people get their employers so enraged that it doesn't work. Yes.
Have you ever had experience treating anyone with Ehlers-Danlos syndrome, and would the contributing factors be the same, because like veins are kind of more valuable and stretchy and things, so?
The question is about Ehlers-Danlos syndrome. Yes, lots and lots of patients with ME/CFS have Ehlers-Danlos. Many more than would have it in the general population. I heard Peter Rowe speak. We were in Sweden actually recently, and Peter Rowe was talking about that. He's got a lot more experience with it than I do. And the incidence of Ehlers-Danlos in ME/CFS is something like 17%, whereas in the general population it's only 4 or 5%. He says that he feels that it's related to the structural integrity of the tissues surrounding the blood vessels. So he says that it's important in that regard. Let's take one more question and then call it quits.
What does the blood volume issue have to do with lymph nodes and sore throats? How are they related?
Absolutely no relationship at all. It's a very good question. But that also relates to the stage of the illness. For the majority of people, the lymph nodes are particularly nasty and the sore throat is particularly nasty in the beginning, the first 5 years. And then those symptoms tend to disappear. Now the blood volume, I can't imagine how it would affect the lymph nodes or the sore throat. However, that I think is a result of the cytokine signature in the first 5 years. Mady Hornig also said in that paper that the cytokine signature was only something you could really look at in the first 5 years, because after that it started to return to normal. So, well, thank you very much. It's been a wonderful. So I'm more than happy to come back to Seattle anytime.